2022 Foustanellas Endowed Lectureship. We are honored this year to resume this lectureship in a hybrid format. Our last Foustanellas lecture was in 2019 with Professor Falk from Berlin. And there's already a long slew of very distinguished speakers for this very prominent endowed lectureship. And this year, we're especially honored to have Professor Mario Gaudino as our endowed speaker. Dr. Gaudino requires no introduction, but I will introduce him. But prior to doing that, I do want to thank the memory of Mr. Peter Foustanellas. Peter and Eva have been wonderful supporters of the Heart Institute and more specifically of cardiac surgery as well, including developments and enhancements in the OR and several others contributions to or better operations, no pun intended. So our speaker today requires no introduction. As I said earlier, Professor Gaudino is the Stephen and Suzanne Weiss Professor of Cardiothoracic Surgery at Cornell in New York. He's also Assistant Dean for Clinical Trials, and he's also Director of their Joint Clinical Trial Unit at Cornell. Mario is obviously a great friend to several of us and yours truly, but also I think we can say that he's arguably, and probably not so arguably, the most productive cardiovascular researcher all around. You know, when I was a fellow with Frank Selke, he instilled in me like this concept of getting your paper every month. You know, where's your paper of the month? You know, because you want to publish about 15 or so papers a year. I would say with Mario, we're now at the concept of where's your paper for the week, or where's your second paper for the week, because he publishes between 80 and 100 papers on a given year. And you can be certain, given Mario's detailed scrutiny of everything that he does and constant quest for perfection, that every single paper is thoroughly reviewed. And we talked about that because as Mario is also a great advocate for ethics in research and says it only takes one bad paper to actually curtail a reputation. So we even more admirative of his productivity and everything he's done for a cardiovascular field. So what he's done, he'll talk today about clinical trials in cardiac surgery, but he's a great advocate of what I consider the very important interface between translational research, cardiology, and cardiac surgery, and by extension, cardiac anesthesia as well. One cannot be successful in the cardiac surgery field if you don't completely understand where the patients come from and the indications that lead to someone needing surgery. Mario has been especially involved with the radial artery from almost its inception, from the modern era of Professor Posati, who was one of his mentors in Rome, publishing on very long-term data of the radial artery, and then continuing on by very landmark individual patient meta-analyses of the radial artery published in the New England Journal of Medicine. His own trials were published in the Lancet, in JAMA as well. He's been the father, quote unquote, of doing a small posterior pericardiectomy to prevent atrial fibrillation post-op by being able to evacuate the blood. And that was a recent key Lancet paper. So I could talk about many, many more achievements that Mario has achieved. He's also a very accomplished surgeon and definitely a great friend. And it's a great privilege to have him as a mentor to our trainees, to our fellows and residents, and to all of us who can understand what he can teach us about clinical trials in surgery and beyond. Dr. Gaudino.
Introduction. And let me just start by saying it's an honor to be here, not only because I keep repeating Ottawa is a family for me, and I have a really very close friendship with many of you, but also this is the place where actually what I've been doing most of my career, evaluating the outcome of bypass conduits has essentially started. I mean, seminal papers about the evaluation and the classification of the outcome of CABG conduits came from this institution. It's a true privilege on many levels to be here. However, today I will discuss something that has nothing to do or very limited to do with CABG, and it's just in general the challenge of clinical trial in surgery in general, not specifically cardiac surgery. And I generally believe that surgical trials are different than drugs trial or medical trial. They have their own specific challenge and issue, and not sure that as a community we have a good understanding of them. So I thought it could be an informative topic, especially for the younger. And so I will start with the bad news. We don't really have a great reputation as a surgeon for doing clinical research. This was Richard Horton, a legendary editor of The Lancet for over 2 decades, that defined our clinical research as a comic opera. And to make things even worse, he was not the first to say so. Back in the 20s, one of the father of biomedical statistics, Dr. Greenwood, used the same definition for our clinical research. So why is that? What is the main critique that Dr. Horton and Greenwood make of clinical research in surgery? Well, the problem, they say, is that most of what we do is observational research. We don't do randomized trial. We just do retrospective observational study. And this is a problem, and I agree, this is a very important problem, because in all fields, but in particular in surgery, observational trial cannot and should, observational study cannot and should not be used to derive the information about the treatment effect. And why is that? Well, you know very well why is that. We are taught from the very beginning of our surgical training that we need to individualize our operation to the patient in front of us. We would not do the same operation in 2 patients that, based on our eyeballing, are different in terms of comorbidity, in terms of anatomy, in terms of many characteristics, and many of those characteristics are not captured in our charts, in our database. So essentially, when we use observational data to compare different treatment, what we are doing, we are comparing the effect of 2 different operations performed on 2 different types of patients, and probably by 2 very different types of surgeons. So it's unlikely that you can derive any meaningful information about the comparative efficacy of the 2 treatments you are comparing. And as Mark mentioned, I am a coronary surgeon, so I will give you an example, a very clear example of that from my field, from coronary surgery. It is a classical meta-analysis looking at one of the most studied issue in coronary surgery, the outcome of patients receiving bilateral versus single internal thoracic artery. This is a meta-analysis of the published evidence over the course of the last 4 decades, all observational study, but we focus in particular on propensity-matched studies. And the reason why we focus on propensity-matched studies is because they are considered the highest level of risk adjustment that you can do in observational research. A lot of people use the wording that I hate of quasi-randomized experiment. They're not randomized, but still is considered the best you can do to adjust for bias and confounders in observational study, okay? So look at the top of the figure. We looked at those study, the primary outcome, the outcome here is all-cause mortality. And then you can see that based on the hazard ratio, that at the end of the follow-up, the median follow-up was 7 years, patients who received bilateral internal thoracic artery had longer survival, significantly longer survival, significantly better survival compared to patients who received a single internal thoracic artery. But then we did some meta-analytic exercise. So we extracted the odds duration in the same study at 1 year of follow-up. And the reason why I picked 1 year is because we know from angiographic randomized comparison that at 1 year, the difference in patency rate between the right internal thoracic artery and the saphenous vein, it's small, is not significant, and it's very unlikely to affect an outcome like all-cause mortality. The other ratio is the same at 1 year. So there is a statistically significant difference in survival between groups at the time point where there is no difference in the biology of the treatment. So this is treatment allocation bias. Healthier patients were receiving the operation that we as a surgeon perceive are long-lasting and potentially better. I think probably as a surgeon, we made the right call, but that has nothing to do with the treatment effect. The patients are living longer because they were healthier to start with. We have no idea if this is related to the treatment or not. And yeah, we are not, I mean, Dr. Orton was right. We are not doing a randomized trial. This is looking at all the evidence published over the course of almost 5 decades. This is surgery, not cardiac surgery. The 10 most commonly performed surgical intervention in the United States. The red line is the overall number of study, and the very small blue line is the number of RCT. And you see how we have done very few RCT, but also look how over the course of the last 20 years, the situation has not improved. And this is cardiac surgery, same. And if you want, probably even worse. You look at the red line that show RCT, the number is going progressively down rather than up. So we are not doing a lot of RCT in surgery and in cardiac surgery. So why is that? Well, this is a summary table that we published a few years ago comparing drug trial or medical trial to surgical trial to highlight the difference. There are a lot of important difference. I will highlight some. Compliance in drug trial is on the patient, in surgical trial is on the surgeons. Co-intervention are generally relatively infrequent and inadvertent in drug trial. They are generally made on purpose in surgical trial. And we have great example, the arterial revascularization trial, where 30% of the patients who were randomized to receive a single ITA also received a radial artery. So that was a perfect example of surgeon-related or surgeon-decided co-intervention. Crossover, I will talk about it later. In general, crossover is a problem for every trial. Statistically speaking, it diluted the treatment effect and introduced bias. However, in surgical trial, crossover, especially from the intervention to the control arm, is generally also a marker for lack of comfort and confidence of the surgeon with the new procedure. And that also opened the question of the deliverability of the intervention in those patients who did not cross over. So in surgical trial, crossover not only had the statistical issue, but it's also a generally red flag for the delivery of the intervention in all the patients, even those who did not cross over. Intervention are clearly much easier in drug trials. You just have to give a pill A versus pill B. For surgery, it's much more complex because it's a complex procedure. There are operator and experience related issues that you just don't see in medical trial. And feasibility also, if you think about it, for a drug trial is essentially depend on the population. But for surgical trial, it depends on the population, but also on the surgeons. Hard to do a surgical trial without getting surgeons involved. This is a relatively old, but still very, very contemporary table looking at the reason why a research question can generally not be easily addressed, surgical research question by an RCT. And you see the key one, well, uncommon condition, yes, the population of patients referred to surgery in general is a minority of patient in the medical field. So that's definitely an issue. But then lack of equipoise from the part of the surgeons or of the patient. So let's discuss that. What is equipoise? So equipoise is the genuine lack of clarity on what is the best intervention in a specific setting. And ethically speaking, it's really the condition that is necessary in order to design an RCT. There are two different levels of equipoise: professional, like as a society, as a whole, we do not know if one treatment is better than the other, but also individual. You, individually, as surgeon, do not know what's the best treatment for your patient. And they generally say that professional equipoise is what in essence determine if a trial or a study should be done. But individual equipoise is what in essence determine if the trial can be done. Because if surgeons do not have individual equipoise, there will be skewed enrollment, there will be probably unconscious bias, and in the end, the result of the trial will probably not be reliable, and we have seen that. I can think of the Stitch trial as the perfect example. And Richard Horton reminds us that it is true. Probably also the personality traits that are generally common among surgeons do not help in a collaborative effort. More generally, to save the surgeon a little bit, I would say that we are used to make very important life of death decision in the matter of seconds based on very incomplete information. That was happening every day in the OR. So probably we don't value, as our medical colleague, solid information that much, but that's a mistake. Or, and that also we must be honest, some of us are so invested in a technique, the radial artery for me, for example, that we may be uncomfortable in testing the technique that essentially is the basis of the foundation of our academic reputation within the context of an RCT, but that's also a huge mistake. For a surgical trial until all of a sudden it's too late. Why is that? Well, in general, surgical innovation, surgical technique are not perfect the moment they are introduced in clinical practice. They are introduced by few visionary surgeons like Mark with Mix, but then they are perfected over the course of some years by early adopter that test the technique, introduces small changes that generally make the technique better. And often industry will step in and produce like a device, an instrument that help. So if you test your technique too early after introduction, the risk is that you are testing an immature concept and you may underestimate the potential beneficial effect. But on the other hand, there is another risk. If you wait too much, and especially if the surgical community or the patient perceive that technique as better, whatever that means, they will just embrace it. And then at that moment, there will be no equipoise anymore for an RCT. And for example, in general surgery, this is what happened with the laparoscopic technique. They were widely adopted before being rigorously tested in RCT. And then we discussed that there is the surgeon effect that is a very important difference compared to medical trial. This is the seminal NIJM paper that the first time showed a very clear association between volume, surgical volume and outcome, including several major surgical procedures, among them cardiac surgery. This is from the ART trial, is a plot that showed the variability in crossover rate from experimental to control among individual surgeons. And you see that the variability goes from 0% to 100%. So clearly, surgeons have different level of comfort and confidence with the operation. You don't see that in drug trial, okay? That's a problem that you don't have if you are testing drug A versus drug B. We have discussed crossover. We know there are statistical issues, but there are issues. It's a huge red flag in interventional trial for deliverability of the operation. We have addressed this using a meta-analytic approach, and we have shown that in the published cardiac surgery trial, when the crossover from experimental to intervention was above 7%, the trials were most likely neutral. There was no treatment effect. And that was exactly for the reason that I discussed above. And understand there is another issue that in general, surgeons have asymmetric experience with the intervention versus the control procedure. The control procedure is the standard of care. It's probably what surgeons know how to do. The experimental procedure is the new procedure, and they clearly have less experience with this new procedure. So that's why there is generally an asymmetric experience that come into play in surgical trial. And again, you don't see that in medical trial. So can we fix that? Yeah, we can. There are a number of design and methodological strategy to address the issue. You can define case volume, that's the simplest approach. You can use monitoring technique, proctor, use a proctor, use pilot phase, run-in period, or use expertise-based design. So that's a good news. We can address the surgeon factor. Now the bad news. One of my very smart fellow did this very nice survey of all the surgical trial published over the course of 12 years. And when we look at how trialists control for surgeon experience, they found that the majority of cases, trialists just ignored the surgeon experience issue, and they designed the surgical trial exactly like it was a drug trial. Monitoring of the intervention was ignored in 95% of the trial. But even more scary is that almost 70% of the trial in their protocol did not provide a detailed description of the experimental intervention. So if you don't even describe the intervention you want to test, how can you expect that there will be a standardized delivery of the operation? So there are methods to address the surgeon effect issue, but we are not using them. Now, a few words for the outcome. What are the outcomes of surgical trial for all trials in general, but in particular in surgery? Well, we all know important clinical events are uncommon, so then we use composite outcome. The key issue is composite outcome, that not only they should share the same pathophysiology, but also ideally they should have very similar clinical importance. And the reason for that is that in general, less clinically relevant events are more frequent than clinically important events, and they will drive the composite outcome. And you can find yourself in a situation where less clinically important event are driving the outcome in the composite outcome in one direction, despite the fact that clinically important events go in the opposite direction. So your composite outcome result is essentially meaningless and potentially dangerous. The other question that is difficult to solve is, in the composite outcome, you generally have death. Now, what kind of death mortality you want to use? All-cause mortality, disease-specific mortality. all-cause mortality is more solid. That's what we generally say, because there is no room for error. There is no room for bias. It's pretty simple to say if someone is dead or alive. On the other hand, cause-specific mortality is more sensible to the treatment effect. And this is not a surgical trial, this is a heart failure trial, but you can see how the treatment effect becomes progressively larger when you go from all-cause mortality to cardiac mortality to mortality due to heart failure. So all-cause mortality is more solid, but less sensitive to the specific treatment effect. Now, blinding is something that is important, especially if you are using outcome that can be influenced by human decision, and that can be open to bias, like quality of life and the length of stay. This is the classic pyramids of different blinding from single to quadruple. Most surgical trials use a single or double blinding. However, there have been some notable exceptions. So this is a Lancet paper that was testing laparoscopic cholecystectomy. And in order to blind the patient to the intervention received, they went to the extent of staining the medication with fake blood. So, I mean, we have done also some very interesting and creative stuff, but in general, the majority of surgical trials use single blinding or double blinding, 0.3% of the trial that my fellow considered in his work. So 1 out of almost 400 was using triple blinding. Enrollment is a major challenge. In that survey that Bryce did, we found that 20% of the surgical trial did not reach the planned sample size, and not by a small amount. I mean, there were almost 40% of the trial that did not reach their sample size by at least 25%. So a pretty large number. Enrollment is definitely a challenge in all trials, but for surgical trial in particular, and even when we reach the sample size, we have major issue with the representation of racial minorities and of women that still represent around 15% of the patient enrolled in cardiac surgery trial, despite all the pressure to increase the representation of women. Funding is another challenge. This is overall NIH funding in the top right of the slide, increasing over the course of the year. But then when you split it to medicine in red versus surgery in blue, you see how the trends are opposite, and surgeons are doing progressively worse. Now, we do not know the denominator here. We do not know if we are submitting less application or our application are less and less competitive, but the reality is funding is a struggle. And industry is not very interested in funding surgical trials where there is no device involved. So this is a comparison of funding sources for surgery versus interventional cardiac surgery versus interventional cardiology trial. First of all, shame on us, look at the difference, the overall difference in numbers of trial. We have been clearly outperformed, but then also look at the split, at the distribution between industry and federal funding or investigator initiated. You see that there is much more interest for industry in interventional cardiology trial rather than surgical trial, but again, no surprise. Now, I was hoping to have some young surgeon at this talk, because I want to discuss briefly superiority versus non-inferiority, just to say that non-inferiority is not the devil. I mean, now there is this concept in the surgical world that non-inferiority trial is just the way that interventional cardiologists are trying to fool us and to bring the trial home. Well, that's not the case. non-inferiority trial have a very solid rationale. Sometimes the benefit of the intervention are not related to an increase in the primary effectiveness of the intervention, but to something else. Less invasive, faster recovery, cost less money. So in that situation, you accept to pay a small price in terms of primary efficacy of the intervention for those additional advantages. And now, I mean, this conversation is about what is this small price and what is the non-inferiority margin. In those situations, a non-inferiority design make all the sense in the world. However, you must also consider that all the design and implementation issue that in a superiority trial would generally bias the analysis toward the null hypothesis. You get your sample size wrong, trial is underpowered, event rate is lower than you expect, you have high crossover rate, higher loss to follow up. All these that in a superiority, all those that in a superiority trial will likely result in a neutral trial, in a non-inferiority trial will likely result in achieving non-inferiority. So simply said, if you do a sloppy job in a superiority trial, you will probably have a neutral trial. If you do a sloppy job in a non-inferiority trial, you're more likely to reach non-inferiority. So this is something that you have to keep in mind, but in general, non-inferiority trial definitely have a reason to be there. Now, I like the fragility index. I am a simple-minded surgeon. I think it's a very intuitive metric of the solidity of the result. It's an old concept that comes from Hamilton, and essentially it applies only to trials that are positive, that I show the significant difference between group, and essentially it's the minimum number of patients who would need to switch from one group to the other to transform a significant result in a non-significant result. So the lower the fragility index, the lower the solidity of the trial result. If the fragility index is 2, it means that the statistically significant difference that you have observed is based on the result of 2 patients. So we looked at the fragility index in surgical trials, and we found that the median was 3. So pretty low. But not only that, Mary Charlton, who was my mentor in clinical epidemiology, always tell me that there is a reason why patients are lost to follow-up. Patients are not lost to follow-up at random, but generally something has happened to them. So we look at the fragility index minus the number of patients lost to follow-up, which is a very relevant metric because, again, patients lost to follow-up probably have experienced an event, and that number is 0. So pretty concerning in terms of the solidity of our result. Another thing I like is reporting bias or spin. Spin apply to neutral trial. And essentially the definition is when a trial is neutral, there is no difference between group. The authors use a reporting technique to try to imply that a difference is there, even though this is not supported by the data. And there are analytical methods to analyze spin and to quantify it and analyze it. So we have a look at spin in surgical trial, neutral surgical trial, and we have found that in more than half of them, there was the use of reporting bias, there was a spin. So definitely another area where we as a surgeon should improve. So what do I think about surgical trial? Well, I think that they are essential. I don't think you can estimate treatment effect in surgery based on observational data. But we need to do better trial. We need to do more trial. We need to understand the specific challenge that trial in surgery have. And like really, please, the young generation, stop doing comparison between different surgical treatment using observational data set, because this is what we have done for 5 decades, and we haven't progressed at all by doing this exercise. However, now you're happy, this is done, we can go to lunch, but I would like to spend 10 minutes discussing what is really close to my heart, and is the PCI versus CABG trial, but I would not get into the controversy between the two techniques. This is just from a purely methodological and trial design perspective. So this is the ARTS trial. Patrick Serruius, New England Journal of Medicine, 2001. Is the father or the godfather of all PCI versus CABG trial. It was published 20 years ago. I'm not sure where you guys were, but probably like at the kindergarten or something like that, okay? So what did Patrick did? 1,200 patients randomized to PCI versus CABG, and he used a primary composite endpoint that included death, MI, stroke, and repeat revascularization. The trial was a superiority trial testing the hypothesis that CABG was better than PCI. That was 2001. It's wrong. Everything is wrong here, and we have been doing that for the last 2 decades. The idea of testing if CABG is better than PCI or PCI is non-inferior to CABG is just wrong. The two interventions are very different. The only thing they have in common is that they target the coronary circulation. The upfront risk is much higher with CABG and lower with PCI, and the long-term benefit is higher with CABG and lower with PCI, but the two interventions are very different and complementary. So the idea of trying to identify a winner is just a silly idea, and it was probably appropriate 20 years ago, but it doesn't make sense now after everything we know about the two techniques. But we are not very smart, and even interventional cardiologists with us, because over the course of the last 20 years, we have keep repeating the ARTS trial. Those are the main trial, PCI versus CABG trial, published over the course of the last 2 decades. They all use either a superiority or a non-inferiority design. They also use a very similar primary composite outcome that included, again, death, stroke, MI, and repeat revascularization. Okay, those are important outcomes. They are cardiovascular outcomes. But what about all these? Do we believe that the patient only care about death, MI, stroke, and repeat revascularization? What about quality of life? What about arrhythmia? What about time in the hospital? What about time to return to work? Renal complication, respiratory complication. And in order to do that, those type of trial to answer this silly question of what technique was better than the other, we have included the minority of the patients. So in the result that we get from those trials just do not apply to the patient that we see every day in clinic. So my vision, that's my personal vision, and it's probably totally wrong, but I hope the new generation of PCI, I think there is room for more PCI versus CABG trial, but just a different generation. I think we should abandon the idea of superiority and non-inferiority. We should expand our primary composite outcome to include a large number of holistic outcomes that really capture the full spectrum of patient experience. We should design large trials that include subgroup and minorities that are generally excluded. And clearly, because we are discussing very large trial, we should probably leverage existing registry to increase efficiency. Sure, funding will be an issue, but must be collaborative. We have a system like GCRFF in place. We had the first surgical trial endorsed by GCRFF. And ideally, all parties should be asked and to some extent mandate to contribute to the funding of those large trials. Trial leadership should be inclusive. I think surgeons should be included. I think interventional cardiology should be included. I don't think that surgeon or interventional cardiology should lead those trials. I think trials should be led either by general cardiologists or even better by methodologists that are not directly involved in the field. I think we need to really switch from those trials that provide the average treatment effect in the average patient that is a totally useless information to trials that provide precise and well-powered estimate of what is the outcome of one intervention and the other, not one against the other, in a large number of patient subgroups that really represent clinical practice. And I believe that the classic academic exercise that we have been doing for the last 2 decades of artificially comparing CABG and PCI in this silly search for the winner is just not representative of what we know about the 2 techniques and is not in our patient best interest. And now this is really over. Thank you for your attention.
Stay there. What a great talk. I think we'll get some questions from online. And Mario, this was really a wonderful presentation. I want to. What are your thoughts around, distilling it down to quality of life and survival long?
Well, even alcohol makes you feel better. So we can have an arm that is randomized to drink alcohol. I'm kidding, but Mark, you're right. The quality of life instruments are not perfect, but that's on us, and we need to work with a quality of life expert to improve our instrument. I mean, John Spertus is a great friend, and will tell that especially the generic instruments are really, really poor, and they don't move unless there are very large variation in patient quality of life. And we need to acknowledge that, but that's a reason to do better instrument, not to go back to arts and 20 years ago. So I think there is a lot of room for improvement, but the direction of trying to really understand what is the patient perspective, not our trials. And I didn't say that, but there is another thing that I hate. So today I tell you everything about I hate about trial, is the time to first event analysis. The time to first event analysis is just ignore everything that happened after the first event. I mean, if you are a patient and you get 2 MI rather than 1 MI, I mean, that's important to you, right? But we just ignore that. And why we ignore that? Well, analytically, it's much easier. You just count the first event and it's much easier to analyze that. But this is why, Mark, I think for the last 2 decades, we have done trials for trialists. Trials that are easier to analyze. We capture the event that we believe are relevant because we are cardiovascular, in the cardiovascular field, so we just focus on cardiovascular outcome. And probably now it's the time that we stop doing a trial for trialists and we started doing a trial for patients.
It's a great answer. I love your suggestion that in people who have so much skin in the game should probably not be running trials.
Yeah.
It should be much more neutral right at the leadership level. And you are so right in that, right? We, like family doctors, people, primary care physicians, right? They often tell us that they have their biases too, right? But they say, well, the funny thing with CABG, as you alluded to, is that we have all these patients who had CABG 25 years ago when now they're dying from colon cancer, right? It's very invasive, but it deals with the problem. But that being said, you know, to your quality of life, if someone hasn't healed their sternotomy, or conversely, if someone's still having angina or having nosebleeds because they're on that, how do we measure these?
Exactly.
Right? They're great points. We have a question from Dr. Jim Robley, Mario was our chair of anesthesia for more than 10 years, who's asking you, what do you see as the role for sham controls in surgical trials?
It's a great question, and I've discussed that in some of the paper I published. I think sham control is very important. I mean, Orbita has been the classic example of a sham-controlled trial that showed very different result. I remember, I'm old enough to have seen all form of attempt at coronary revascularization, but Mark probably remember the TMR trials that were generally positive, where there was no sham control, and then they were neutral when there was a sham control. So it is important. However, there are clearly ethical issues for a sham control surgical trial, because essentially patients needed to undergo anesthesia and sham surgery, so they take the risk of surgery without any potential expected benefit on an individual level. So ethically speaking, this is justified only if the solidity of the information achieved by doing that is so important for the community at large that you can accept, or is ethically acceptable to pay the individual price. But it's clearly the ethical concern are more than in placebo-controlled trial.
Talk very, very educational and informative. I have two questions. The first is, how do you deal with evolution of technology? And you know, it could be surgical approaches, interventional approaches, imaging, what have you. Because as you start the trial, you design it with you know what's at the ground level. But during the course of the trial, or 5 years, the way things are accelerating, you can have advances in care and treatment, both medical, surgical, whatever. So how do you suggest that that we deal with that problem?
So clearly, one of the, I always say, the problem of there is a tension between the fact that we want to have long-term data, but clearly long-term data reflect older practice, right? If you have 10 years follow-up, yes, those patients were operated or got PCI 10 years ago. However, I think now we have adaptive trial design, where over the course of the trial, you can modify the protocol. Generally, you don't modify your control group, so you increase efficiency, and you can introduce in the trial variation of the technique that have been developed. So there are ways of addressing it methodologically, but it is true that trials are generally a little bit behind clinical practice, and I don't think there is a great solution for that.
So thank you. My other question is really relates to equipoise, and I don't mean to pick on the ischemia trial, but it's the one that comes to mind, whereby you have patients where people are willing to randomize because they're not certain it's going to make a difference, yet the patient population that they were targeting, most of those patients never got into the trial because of the equipoise for intervention or not, depending on the site, et cetera, et cetera. So what ends up happening is you end up with a trial that's effectively negative because you've missed the bulk of the population. So I like your last slide. We were talking about larger populations, but are there other ways that we can kind of try to address that?
Well, yeah, I mean, and we have seen that in surgery a lot of the time. What happened is that surgeon or interventional cardiologist, they have equipoise in general. So there is community equipoise, but individually, they are willing to randomize only those patients where they are unsure about the treatment effect. But there are many more patients where they firmly believe there is a benefit, and they will not randomize those patients. So the trial will essentially be biased toward showing whatever the research hypothesis was, because the patient population that could benefit from one of the two interventions was excluded. So the answer is both on an individual level. I think if you are committed to a trial and you truly believe that, well, let me reward. If you should commit to enroll patient in a trial only if you believe that research question is so important that you are okay enrolling every patient that meet the eligibility criteria in that trial. If you don't have that individual equipoise, then you shouldn't enroll. And that's in Roma, in my trial, I always tell, if you are okay randomizing patient to one or the other intervention, happy that you join. But if you don't, please don't join. I don't want you to enroll only those patients where we are not sure what the outcome will be. So that's a problem. But in general, I think trials should be descriptive rather than trying to it's a different concept. I think the real issue has been this obsession of showing statistical superiority, and that has essentially driven everything. I think we should design something that is in between a randomized trial and a registry, where we enroll almost every patient that we see, and we provide a very high quality description of what the outcome are in each specific subset, and this will inform the decision making. Because if tomorrow you have a 78-year-old guy with renal failure and other comorbidity that asks you, well, what's going to happen to me if I do PCI or CABG? What are the relative difference? Your answer is, I have no idea, because patients like you have not been included in the PCI versus CABG trial. Whereas if you had at least solid estimate of treatment effect without necessarily saying one intervention is better than the other, you could say, look, if you do PCI, this is your risk of like MI at 3 years. If you do CABG, this is your risk of stroke at 1 year. And then you could, so you preserve randomization because of the reason I have described about the challenge with observational study, but you're not obsessed with this idea of defining superiority versus inferiority. You just described what is the event rate in different population.
The excellent talk. I really enjoyed it. I wanted to just share with you an observation, maybe just get your comments on this. You know, I think you've said on one hand that higher degree of specificity in a trial, defining exactly what the treatment intervention is going to be and the way it's going to be carried out is beneficial because it standardizes the intervention and leads to a higher quality trial. On the other hand, we know that the more we specify to a surgeon how to do something, they may have their own set of ways of doing things, that we perhaps lose people as potential enrollers and participants in the trial. So, you know, I'm in the space where we're doing a randomized trial looking at a treatment decision. Patients who have aortic aneurysms between 5 and 5.5, do we have them undergo surgery or surveillance. If I was to go on and say, if you do surgery, you need to do surgery exactly in this manner. And if you have an aortic root, you need to do either a Bentall or a valve sparing. And if you have an arch, if I do that, I will lose all of my potential investigators to participation in this trial. So we feel this push and pull between higher quality and feasibility. I don't know if you have comments on where we, as surgeons, when we design our trials, where do we kind of draw that balance between whether we can get something like this done or not, versus aiming for that really high standard?
I have an answer, and actually I have an example, and the example is in the pericardiotomy trial. So for the pericardiotomy trial, to address the question, first I designed a mechanistic trial. Single center, the intervention was highly specified. There was only one way of performing the intervention. All the surgeons agree upon that. It was at very strict entry criteria. Our primary outcome was for a proof of concept was not a clinical event, it was AFib rate based on telemetry, so even very sensitive outcome. And then once we shown based on a mechanistic proof of concept trial that the intervention worked, now we are designing a multi-center confirmatory trial where we will not tell surgeon how to do the procedure, but we will ask surgeon post-hoc, how did you do your procedure? So that we could look at the effect of different variation in the intervention on the treatment effect. So I don't think you can do that in a single trial, but the idea of designing first a very rigorous proof of concept trial, and then if positive, test it in a confirmatory multi-center pragmatic trial, that's probably the way to go.
Usual. Two questions. First, very practical. Where do you see the place of patency trial? So we had in the 90s and in the early 2000s a lot of patency trials, and since 2010 in coronary surgery it has completely disappeared. So do you think that there's still a future for these patency trial, or we just should focus on clinical events and everything you talked about? Second question is for my young colleagues here on the first row is, I am more and more doubtful that cardiac surgeons are able to do what you've been able to do in the last 5 years. And you're the living example that you have changed. What I mean by that is, do you still think that you can do 250 to 300 operations a year and be doing what you do today? So don't you think that pure, very high quality research has to be dedicated to a handful of people in order to achieve the goal that you showed, rather than to do what we've been doing for the last 20 years, which is doing research after 6 p.m. and during the weekend? Thank you.
Well, those are really great questions, David. Thank you. So first, let me start with the easy one. Patency trials are important. I am a great supporter. However, funding agencies do not like patency trial because they see patency as just a surrogate outcome that, however, expose the patient to the risk of re-angiography or CT. So in general, it's very hard to get a patency trial funded. However, and what we did with Mark recently with Odin, there are models, there are statistical models like the win ratio, when you incorporate patency in a composite outcome. So you look also at clinical event, including patency, and funding agency generally like this approach better, but still, unfortunately, if your primary composite outcome include patency, be prepared that you may have pushback because of that. But I think it's a mistake because for the first stage, for mechanistic trial, patency data are really important. Now, the second question, I think, David, you cannot do surgical research if you are not a good surgeon. You need to understand the trials. You need to understand the methodology, but you need to know what surgery is. Because if not, you are just one of the many trialists. But surgical trialist is a different beast. It's someone that knows what's happening in the OR, know the challenge of surgery, and know trials. So unfortunately, yes, the easy answer would be, sure, we pick the best of us, we put them in charge of designing surgical trials, we support them, and we go to the OR. But then that's not going to work. Because if you are not a surgeon, I don't think you can be a good surgical trialist.
Well, on this wonderful closing acumen, I want to thank you, Mario, on behalf of the Heart Institute for being our 2022 Foustanellas Endowed Lecturer. And we have to get you to your car, because otherwise there's a small risk that you might miss your plane. And again, on behalf of Division of Cardiac Surgery, I want to thank you all for attending, those online and those here in person. And most of all, again, thank you, Mario, for a wonderful lecture, very much in keeping with the high caliber of this endowed lectureship. Thanks so much.
Thank you, Mark. Thank you.